I am Dr. Sandeep Dachuri. I am an ENT surgeon at JAM ENT Snoring Clinic. I have done my MS ENT from KMC Manipal, and followed by that I have done a snoring fellowship at Italy under Professor Claudio Vicini. Uh, most of the topics have been covered already by most of the physicians, so I will be skimming through those slides and mainly focusing on the surgical aspect. So, sleep medicine is perhaps the youngest medical specialty, as all of us know, and most neglected also by both the patients and physicians. Uh, the earliest descriptions were by Charles Dickens in Pickwickian papers in 1836 and 37, and he has explained a lot of features in this boy, Joe. And these slides have already been presented. It's a spectrum and and my main point is sleep disordered breathing requires multidisciplinary. It's not working. Multidisciplinary approach, and as physicians and ENT and pulmonologists, we should treat these patients together. And most of the patients, they come to the physicians first and followed by the surgeons. I don't want to go into these details because they have been extensively discussed, the symptoms of OSA, how they present in children, and what happens if they get untreated. Um, Coming to the pathophysiology, this upper airway, unlike other mammals where the larynx is near the skull base, in humans it's in the neck. So there is a muscular tube which can become loose as we age, and around it fat can get deposited, and it can become narrow. So main reason for collapse of the airway is relaxation of the pharyngeal dilator muscles during sleep. And obesity, as everybody has spoken already, is one of the main reasons for this OSA. Coming to ENT part, the obstruction can be mainly at three levels. One is the nose, and then nasopharynx, oropharynx, and hypopharyngeal levels. Coming to the nose, it could be a septal deviation or turbinate hypertrophy, nasal wall collapse, or adenoid hypertrophy in the nasopharynx. Coming to the soft palate, it could be a bulky soft palate or a macroglacia, or it could be in the hypopharynx where the epiglottis is the culprit, omega shaped epiglottis, or it could be lingual tonsillar hypertrophy, or it could be at the level of glottis, true vocal cord paralysis. I have seen a couple of cases where patient has bilateral vocal cord paralysis and patient is having huge snoring, and they have not been diagnosed with vocal cord paralysis for a long time. So, as physicians, how to identify these patients? We have to, thoroughly take history. If there is any unexplained hypertension, we should be able to identify them. And all this has been covered: Epworth sleepiness scale, stop bank questionnaire, everything. Coming to the evaluation of this patient by an ENT. So the role of ENT is to identify who is a surgical candidate and who is not a surgical candidate. To perform fiber optic nasopharyngoscopy is an important evaluation tool in all of these patients. Any patient who comes with symptoms of OSA should be evaluated by fiber optic nasopharyngoscopy, and polysomnography has been dealt extensively, and I would like to touch upon a little bit about regarding DISE, drug-induced sleep endoscopy. So this is a basic nasal endoscopy in the OPD, which has been performed. You can see the left nasal cavity is very roomy, and there is inferior turbinate hypertrophy, whereas the right nasal cavity has got a deviated nasal septum. You can obviously make out there is no space that side. So this is a rigid endoscope, simple rigid endoscopy. Coming to evaluation of the patient by an ENT, we usually see for soft tissue structures, that is Friedman tongue position. Friedman tongue position is graded from 1 to 4. I don't want to go into the details. It's just like Mallampati score where you keep the tongue inside. Next, coming to the tonsillar hypertrophy, it's graded from grade 0 to grade 4. Grade 0 is no tonsils to grade 4 is kissing tonsils, and this is the adenoid hypertrophy. So we need to do a flexible scopy, identify the different levels of obstruction, what the patient has got, and Friedman has classified patients into clinical stages. Based on the stage of the patient, he has described the success rate is around 80% if the patient has got stage 1, and if the disease is stage 2, 37%, and if the disease is stage 3, it's just 8.1%. The bigger the tonsils, according to him, the better the results. And I don't want to go into polysomnography or any definitions of OSA, and all of us know this grading mild, moderate, and severe OSA. Um, Coming to the management of these patients, I explain the patients just like asthma or hypertension. This is a chronic condition. There is no absolute 100% cure. You need to be, in touch with the pulmonologist and ENT. And I explain the risk factors. Coming to management, it is both medical and surgical. Dr. Vishweshwaran was telling me, which patients to refer exactly to ENT. That is the main topic. That's what he was telling. But I think that it's like flying a flight. You have a co-pilot, so the pulmonologist and ENT should take care of these patients together. I feel that every patient should be seen by an ENT if they have got OSA, because there are multiple levels of obstruction. It's not a single like stridor or something. It's multiple level of obstruction. So a ENT has to see these cases. Coming to medical management, weight reduction and using multiple devices are there, including CPAP, and surgical management, airway surgeries and bariatric surgeries if the BMI is too high. And we usually don't operate if the BMI is above 32 or above 34, and we refer the patient to the pulmonologist to start them on CPAP, reduce the weight. And if the patient has got morbid obesity like 40 kg per meter square, we directly refer them to the bariatric surgeon. I don't want to talk about the CPAP and interfaces. And as my previous surgeon has clearly told, while using CPAP, it's not that easy. If we wear it for a week, we will know what CPAP is. It's not easy to use. Adherence is almost like 50 to 60% only. They'll have rhinorrhea, aerophagia, rash over the face, and once they slowly get used to it, they will accept it. So there are some oral appliances also used in the treatment of OSA, mostly used by maxillofacial surgeons, like mandibular advancement devices. In mild cases who have snoring, they can use these mandibular advancement devices which pull the lower jaw forward and prevent the tongue from falling forwards. These are tongue retaining devices which are not popular because it's very difficult to sleep with these tongue retaining devices. And there are some side effects of these oral appliances also, like bite changes, TMJ issues, dry mouth, gum irritation.
Sandeep, please go to the directly to surgical part.
Yes. I'll just touch a few points on drug-induced sleep endoscopy. My colleague will be speaking during stations. Propofol or dexmedetomidine is used, as we cannot do a flexible scopy when the patient is sleeping. Obviously, he will sit. We induce sleep to the patient in the operation theatre in the presence of an anesthetist, and we put a flexible scope and make them to sleep, and then we see different levels of obstruction where all they are obstructing. See, in this there is an anteroposterior collapse, whereas in this there is a circumferential collapse in the retropalatal region. So this is a case where there is an anteroposterior collapse in the epiglottic region. These patients, they don't do good with CPAP. If you give CPAP, they will say that they are choking when they start using the CPAP. So these patients are patients who needs to be addressed by a surgeon. And in this case, there is a lateral collapse of the epiglottis. And this is a staging system for drug-induced sleep endoscopy. This is a lingual tonsillar hypertrophy. uh, adenoid hypertrophy. Most of these, CPAP will not address these things, and we need surgical intervention in certain cases. So, cysts or growths in the larynx, surgical management based on the DICE findings. It's not a one blanket fits for all or one thing fits for all. We need to tailor the treatment for each patient. And advantages of surgery is it's 100% adherence. Okay, patient once is on the table, it's 100% adherence, and it's not like CPAP. And it can be employed in an adjunctive role to improve the adherence to medical treatments. And in the recent years, there is a lot of shift in the surgeries also. There is a lot of development technologically. So the important things for surgery is selection of the surgical facility. Always, there are some few ENT surgeons here. Always try to do these kind of cases in a bigger setup where there is ICU, where there are a lot of anesthetists available, and we have to take reflux precautions during these surgeries, and proper communication with the anesthesia team from the beginning, and be prepared for difficult ventilation or intubation. You should have all LMAs, flexible fiber optic scopes ready while doing these kind of surgeries, and don't try to do this in a smaller setup. And both the anesthesiologist and surgeon should be available during intubation, induction, and until the extubation of the patient. I've seen a lot of surgeons, they just go out of the OT to see some other patient, or they have some other case in other OT, and that is the time when we see a lot of complications. And post-op analgesia, oxygenation, keeping them on CPAP immediately after surgery, all these are very important, and all these facilities should be there in the coming to surgeries. As I have told, if there is a deviated nasal septum, you need septoplasty. If there are huge turbinates, he needs a turbinoplasty. Adenoidectomy, if it is a child, usually they will need adenotonsillectomy if they are grade 3 or grade 4. And if there are polyps, they need FES. These are the cases sometimes missed even by some of the ENTs. Patient will be having a polyp, and they will be sent to the pulmonologist for a PAP therapy. So we should not miss these kind of cases. And this is adenoidectomy, tonsillectomy, and there are multiple palatal surgeries. What I would like to tell is snoring surgery is not UPPP. UPPP was done in 1979 by Fujita, and still that brand is there, that snoring surgery is UPPP. UPPP is very old surgery, even older than CPAP. CPAP came in 1981, and UPPP came in 1979. But everybody has got the impression that snoring surgery is UPPP. No. Even surgeries have advanced a lot. So there are palatal radio frequency where you can stiffen the palate by giving radio frequency. Palatal implants have come, but they are not being used because they are getting extruded frequently. If the patient has got just snoring, you can give injection snoroplasty where you give chemical into the soft palate and it will stiffen the soft palate. This is the UPPP, which has been explained in 1979, but there are a lot of complications. These are Gothic arches kind of palates which we see if we see older patients who have undergone UPPP. Now, Dr. Kenny Pang from Singapore has this technique, expansion sphincter pharyngoplasty, and he has published almost the results are 80%. So 80% of the patients are relieved of their symptoms. This is zeta pharyngoplasty, where we remove the mucosa of the uvula and the soft palate, and the palate is stitched backwards. It is a little bit morbid procedure. This is described by Friedman, and this is one of my favorite, that is barbed pharyngoplasty, initially described by Mantovani, and then modified by Claudio Vicini. Here, we are not resecting anything. We just remove the tonsil, and we are repositioning everything in with the help of a barbed wire, where we don't put any knot. We just pull the soft palate forwards. We have published this in Indian population, and these results are almost as equal as expansion sphincter pharyngoplasty. Most of the patients are doing good. Almost 80 to 90% patients are doing good, but you have to select the patient carefully. This is publication by Professor Claudio Vicini regarding barbed pharyngoplasty. You can go through it. You can see on table here only the tube is fitting in his palate, whereas after surgery you can see almost 2 centimeters space has come in the transverse direction. So coming to hypopharyngeal surgeries, even the base of tongue has got tonsil. So if the lingual tonsil is too huge, if the patient has chronic GRD, the lingual tonsils will be too huge. You can do lingual tonsillectomy like this is being performed by a robot. But base of tongue surgeries, you have to do it very cautiously because the lingual artery will be superficial there, and lingual artery bleeds are very dangerous. And laser partial epiglotectomy, this androposture flap door kind of trap door kind of epiglottis, you need to do epiglottoplasty or partial epiglotectomy, but you have to do a barium swallow in these kind of patients because if the patient has already got aspiration, you cannot do these kind of procedures. And tongue based radio frequencies have come. And after soft tissues have been addressed, there are some bony surgeries like genoglossal advancement, hyoid suspension, where the hyoid and the thyroid cartilage are sutured together. And this is like the ultimate, the maxillomandibular advancement. This is useful in patients who have got small mandibles, who have got hypoplastic maxilla. This is a morbid procedure, but gives good results in those patients. And this is the latest development where upper airway stimulation syndrome, stimulation system, where they keep a implanted pulse generator and it is connected to the hypoglossal nerve. So hypoglossal nerve supplies to the genioglossus muscle, which is the main dilator or opener of the airway. So whenever the patient is having apneic episode, the machine will give stimulation and the genioglossus muscle will get activated. This machine will cost around 40 lakhs. It's not available in India. So hopefully it will come in future. So take home message is CPAP is accepted as gold standard treatment, but it is not the only solution. Selecting the right patient for surgery is very important. For surgery, nasal surgery is pivotal, and I do in each and every patient, nasal part, but not the primary. Palate surgeries must be reconstructive, not ablative. They should be reconstructive. You cannot remove everything. OSA surgery is not simple UPPP. That impression should go. And tongue surgery is crucial, but careful operating. Be careful because tongue bleeds are lethal. And team approach is the crux. I think that both ENT and pulmonologist should take care of these patients. Thank you.